Welcome everyone to this spotlight session of the Johns Hopkins Center for Global Health's COVID-19 Strategy Seminar Series. From April to September, we had a series of 34 sessions designed specifically to highlight strategies to support the COVID-19 response in low and middle income countries. We're taking a little break, and today we're taking a new approach as well through this spotlight session, really diving into the inequities apparent in the United States during the COVID-19 pandemic. We have 7 members of the Pandemic Pulse team presenting their preliminary results today. I'm going to turn this over to Dr. Alain Lebrique to introduce himself, the team, and the project. But first, a few notes about processes and procedures for today. So please feel free to introduce yourself in the chat and have discussions there. But if you have any questions, please place them in the Q&A box. They'll either get answered live by a team member or one of the panelists may type in an answer. But if you have any questions, it's really best to put them in the Q&A box and reserve chat for chatting. So with that, over to you, Dr. Lebrique, and to the rest of the team. Thank you so much for joining us.
Thank you, Anna, and thanks to the Center for Global Health for hosting this special seminar. Good morning, afternoon, and evening, and welcome to everyone. I'm Alain Lebrique, a professor and associate chair for research for the Department of International Health at the Bloomberg School of Public Health. I have the privilege of directing the JHU Global mHealth Initiative, which is leading the work which is being presented today. Today, we bring to you the preliminary results of work that is part of a larger project across Johns Hopkins looking at inequities in the COVID-19 pandemic. It has really been a privilege to be sponsored by the Johnson & Johnson Foundation. And this work, the Pandemic Pulse, has a number of arms, one of which is focused on capturing the national pulse of the population during these difficult times. Our goal is to help inform and drive public policy, investment, and interventions leveraging rapid, real-time, high-quality data. In close collaboration with the Department of Epidemiology, the Center for Health Equity, and others across the university, we're pursuing a number of important threads to better understand the inequities in drivers and consequences of this pandemic in marginalized and minority populations, both here in the US and globally. We anticipate that this will be the first of many such webinars, which will be recorded and made available on the covidinequities.org website. That includes publications, recorded webinars, and policy briefs which come from this data, as well as interactive dashboards that are under development to be hosted on the site that will allow people to explore aspects of the national pandemic pulses as the data is aggregated. Today, it's really my privilege to be joined by a phenomenal team of scientists and data explorers, all of whom have been working around the clock over the past several weeks to have this first look at the data ready for all of you. And it's really unique because it's still being analyzed and digested, but because of the urgency to act now, we really wanted to make sure we took as many pains as we could to make this data available in short order. We have with us today Drs. Dustin Gibson, Daniel Urchik, Ankita Meghani, Alex Zapp, Jeffrey Edwards, and Smisha Agarwal. This exceptional team really represents a breadth of experience and research backgrounds, all of which are being brought to bear on the Pandemic Pulse work that you're going to hear about. As many have noted in the past several months, the US epidemic has not affected all Americans in the same way. We've seen a markedly higher infection and mortality rate among minority communities, especially among Black, Latino, and Native American populations. This unacceptable difference is driven by, and in many cases has shown a light on many, many decades of compounded inequities and injustice, resulting in socioeconomic disparities that exacerbate the effects of a pandemic, such as the COVID-19 one we're experiencing currently. As Boyd and colleagues elegantly framed this some months ago in Health Affairs, this disproportionate mortality exposes deep-rooted institutional racism that is at the heart of much of what we see today with the US epidemic. The CDC has identified a number of factors, some of which we'll be exploring in these national pandemic pulses, which contribute to this increased risk and adverse outcomes, ranging from discrimination to healthcare access and utilization, to engagement in essential work occupations that place people at higher risk of exposure, education, income, and wealth gaps that exacerbate conditions in our communities have led to these increased risks as well as adverse outcomes. And not to mention secondary effects such as housing conditions that exacerbate risk of exposure, increase the risk of underlying conditions because of the built environment, and reduce the likelihood of timely testing, care seeking, and of course, the receipt of equitable care. I want to take a moment to make it very clear that this research aims to describe these differences in perceptions of risk, in occupational and social exposures, in access to information and support and care, as well as the associated anxiety and stigma and loss of agency that has occurred during this COVID-19 pandemic. It should be very clear that we are using race here as a socio-political framework and certainly not a biologic one, to examine the underlying systemic racism and its consequent inequities. The same is true for ethnicity. Now, given the nature of this study, there are clear limitations to the degree of nuance that can be captured in this type of longitudinal survey, as well as addressed in the analysis. I also want to make it clear that today we're getting a privileged first look at some of these preliminary results from the first of what we hope to be many national surveys over the coming months. And more nuanced analyses are still underway, and these will be, of course, presented in the peer-reviewed literature. The estimates that are presented today may change as the models are refined and adjusted. And despite the fact that we do have about 90 minutes together, we will only be focusing on 7 modules. And hopefully with all of the Zoom overload that we've all been experiencing over the past 7 months, you will bear with us till the end of this session, because we really do have a lot of exciting stuff to share with each of you. So with that, it's my pleasure to introduce the first of our speakers, Dustin Gibson, who will walk us through the introduction and overview of the survey. Over to you, Dustin.
Thanks, Alan. I hope everyone can hear me. And particularly thank you for framing our current work and putting it in perspective. I'll just spend the next few slides as sort of more of an introduction to go over the rationale and methodology before I turn it over to each of the individual speakers to delve into our COVID-19 topics. With that said, there are numerous trackers out there that tend to monitor downstream outcomes like cases, deaths, symptoms, but very few that measure upstream indicators, such as risk perceptions, preventative behaviors, NPI use, etc., all of which are very helpful to guide public health action and policy. Alan, do you want to advance the slide? Oh, there we go. So as Alan pointed out, our overview is to really just quickly capture the pulse of the nation through multiple cross-sectional surveys over time. This survey contains questions from existing COVID surveys that have been out there done by other respected institutions, as well as those identified by team members at Hopkins that appear to be lacking in the literature. The final questionnaire was reviewed by folks here in the School of Medicine and School of Public Health before doing some initial pilot testing. And as Alan said, we conducted our first survey in early September with plans for 3 or 4 more surveys to be conducted about 2 weeks apart. The surveys contain a core set of questions, COVID related, that we'll be asking each round so that we can monitor their trends over time. And what's nice is we also have the flexibility to add in trending topics or things that have just come out in the news. So for example, in September, when schools were reopening, we decided to place a module on that. I think unique to our survey is that there have been national surveys out there, but we have sampled the African American and Latino communities so that we have sufficient statistical power to examine some of these health disparities and equities between race and ethnicity. We've also developed, as Alan alluded to, a beta dashboard that will soon be made available to the public so that people can look at it and make their own conclusions. This is just an example for the treatment module, the 3 questions up top. And on the bottom, you can see that we're able to filter by age, education, gender, race, and census tract. So allowing a more granular subgroup type of analysis. And I should just mention many thanks to Madhu Jaral for her help in putting together this dashboard. So in short, we contracted data, which is Dynata, which is one of the largest first party data platforms out there with over 13 million participants, panelists. And Dynata sent email requests to a targeted but random sample to create a nationally representative survey across gender, age, race, the census tract, and income. This was an online survey programmed onto an enterprise version of SurveyMonkey, and participants who consented and were aged 18 years and older were allowed to take the survey. And we were able to complete about 1,500, obtain 1,500 complete surveys in a little under a week. For this first round, we had about 8 or 9 modules, which we'll be presenting today. So we have our sociodemographic characteristics, the testing cascade, risk behavior perceptions, vaccine and treatment attitude and perceptions, myths and misinformation, stigma agency, how to safely reopen schools, pregnancy ANC, and higher education. I won't spend too much time on this slide other than to point out that you can see in blue is the census data and in red is our pandemic pulse survey data that our quota sampling approach produced similar estimates to those on gender, race, ethnicity, age, and census tract. There will be weighting, post-stratification weighting done, to really tighten these up, but overall, this approach looked quite well. And in the pie chart, this just shows the household income distribution for our sample, with about 30% of the sample indicating an income less than 30,000, which is in line with some of the estimates out there by monetary groups. So I think that hopefully sets the stage up, just a brief overview of the method so that we can now go into each of these topics. So with that, I'll now pass the baton to Dr. Dan Urchik to talk about risk perceptions.
Thanks very much, Dustin. It's great to be here today with you all. So I'll be presenting on risk perceptions during the COVID-19 pandemic. Let's see. Sorry, I'm just trying to advance the slide. There we go. Okay, so this is just a quick overview of our methods. All survey participants were asked this question about a list of activities. How safe or unsafe do you think the following activities are in terms of you're getting COVID-19 or giving COVID-19 to someone else? And this question was asked for a list of 13 different activities. As you can see in the screenshot on the right, survey participants could choose from 6 different response options: extremely safe, somewhat unsafe, extremely unsafe, unsure, or prefer not to say. So for our analyses that I'll present in the next couple of slides, I collapsed the extremely and somewhat categories for both safe and unsafe. There were 2 primary research questions that we were interested in for this module. They're listed there on the left. How safe or unsafe do people feel about certain activities, and how do their perceptions differ by participant characteristics. So in the next few slides, I will run through an overview of our results. Okay, so here you can see first off the 13 different activities we asked about in the survey along the bottom, just to get a sense of what we're talking about. Attending a gathering of 100, attending a gathering of 10, going to church, visiting elderly relatives, dining indoor or outdoor, visiting friends indoor or outdoor, returning to work, and then things like going to the dentist or doctor, visiting the ER if necessary, and then going to the grocery store. So as you can see, the prevalence of perceiving these activities as unsafe ranges from a high of 74% to a low of 29%. This red line here in the middle is the 50% mark. So for activities like gathering of 100 or gathering of 10, going to church, visiting elderly relatives or restaurants, more than half of participants felt these activities were extremely unsafe or somewhat unsafe. On the other end of the scale, things like going to the grocery store, going to the doctor or dentist, visiting friends, more than half of participants felt like these activities were safe things to do. Interestingly, the prevalence of unsure ranges from 4% for a number of activities actually to 8% for visiting elderly relatives to a high of 11% for returning to work. So these are spider diagrams. They show the percent of people who responded unsafe for each of these activities broken down by participant characteristics. In this case, we looked at race, age, and reported political affiliation. So just some kind of observations. For some of these activities, the risk perceptions are similar between groups, but generally what we found was that for older respondents, they tended to perceive activities as more unsafe compared to younger respondents. A higher proportion of African American and Hispanic respondents reported perceiving activities as unsafe relative to white respondents. And really the most striking divide, I think, in this slide is seen for political affiliation. A much higher proportion of Democrats and independents reported these activities as unsafe compared to Republicans. Or put another way, Republicans were more likely to perceive these activities as safe. And just to give you an example, for dining indoors at a restaurant, this question, 40% of Republicans reported this as an unsafe activity in their perception versus 70% of Democrats thinking it was unsafe. So that's a 30% difference. So here we look a little bit closer at our second research question, which was how do risk perceptions differ by participant characteristics? These are forest plots that show the adjusted odds ratios and 95% confidence intervals of perceiving an activity as unsafe by different participant characteristics. So essentially what we're asking here is how strongly each characteristic is associated relative to the reference group with a perception of unsafe for a specific activity independent of other factors. The odds ratios deviate, let's see. Yeah, we're back on the right side, great. Odds ratios that deviate far to the left or to the right of this dotted line in the middle at 1 represent stronger associations with a response of unsafe between that characteristic and the reference group for the specific activity in question. So in this diagram, we've presented the results for 4 different activities related to gathering or dining. So they are specifically gathering of 10, attending a gathering of 100, dining indoor and dining outdoor. So each color represents the results of a single logistic regression model with one activity as the outcome. And here we're actually presenting 4 separate models in the slide. So just to give you an example, you can see this red dot, almost farthest to the right for the 65 and older category. This dot lines up more or less with 3 on the x-axis. So this means that respondents 65 and older had 3 times the odds relative to young people ages 18 to 24 of feeling that attending a gathering of 100+ people was unsafe. So some takeaways from this slide, I'm just going to highlight some of these areas that I want to talk about. Generally, age groups 45 and up were more likely to view gatherings and indoor dining as unsafe relative to the younger age group. Males were more likely to view gatherings and dining as safe. African American and Hispanic respondents were more likely to perceive outdoor dining as unsafe. There was really not a huge or significant difference by level of education. However, higher income groups were more likely to perceive dining in or outdoors as safe. And finally, for this slide, Democrats and independents, similar to what we saw for the spider diagrams, were more likely to view activities as unsafe relative to Republicans. So again, here we have a similar figure for 4 additional models. These are grouped together because they represent sort of essential activities, things like going to the grocery store, going to the doctor, going to the dentist, or returning to work. So some key results from these models include that older groups were more likely to view going to the grocery store or the doctor as safe, but returning to work as more unsafe. Males were more likely, again, to view activities as safe. There was a slight trend here towards African Americans and Hispanic respondents being more likely to perceive these activities as unsafe relative to the reference. And again, there's no significant differences really by level of education. Higher income groups were more likely to perceive all of these activities as safe, and Democrats and independents were more likely to view most of these activities as unsafe. So lastly, just to summarize some of the overall conclusions from this analysis, older groups relative to younger perceive activities as more unsafe. Males in higher income groups perceive activities as more safe. Democrats and independents relative to Republicans tended to view activities as more unsafe. And we did observe an interaction between age and race for some, but not all activities. One example is visiting elderly relatives. Younger white respondents were more likely to report activities as unsafe relative to younger African American respondents. However, at older ages, there was less of a difference between the race categories in risk perceptions for these variables. So a couple of next steps in future research. We'd like to continue to explore these interactions between participant characteristics, also to look at the data by region and look at the extremely safe and extremely unsafe categories versus the somewhat categories individually. And finally, describe the change in risk perceptions over time as the situation changes through additional surveys. So thanks very much, everyone, and over to the next module.
Great. So we were also interested in looking at the impact of COVID-19 on the pregnant population. And in our cohort, we identified 63 women who reported being currently pregnant. What we were able to do is use propensity score matching to identify a similar cohort of non-pregnant women. And they were matched on age, race, ethnicity, income, and region, and education, so on 5 variables. And so there is, in this slide, all you see that they were fairly well matched, and we were able to find on average about 3 controls for each identified case, where the case is defined as a pregnant woman. So picking up from where Dan left off, we also looked at risk perceptions of these pregnant women across a range of essential activities and social activities. So essential activities are like going to church, groceries, visiting a doctor, ER, returning to work, and visiting elderly relatives. And so the colors here are different from the last slide, but at the bottom you see is safe and the safety, and on top is unsafe, and then the first bar is pregnant and the next bar is not pregnant. So interestingly, across all essential activities, as well as across all social activities, which is on the next slide, we saw, counter to our a priori hypotheses, that pregnant women have a lower risk perception for activities. So they considered all essential activities as well as all social activities on average to be safer. So going to the church compared to the non-pregnant group, they considered going to church to be safer. You'll see an asterisk here representing significance. Now, let me actually annotate that. So you'll see an asterisk here representing significance and returning to work. So on average, they perceive these activities to be safer. Similarly, like I mentioned before, they perceived activities of gatherings of 10 or more people, gatherings of 100 or more people, indoor, outdoor gatherings to be safer than the non-pregnant cohort. And we're still exploring why we might see this, especially because this was counter to our hypothesis. And some of the factors may include, given that pregnant women are already seeking care outdoors as a requirement, they may have children, other children. We don't have information on parity, and they might be participating in daycare and other activities that may result in sort of a different risk perception than the non-pregnant matched cohort. So, okay. So moving on to looking at the testing needs, access to testing and hospitalization cascade for this group. Over here, the numbers get fairly small, but they are still informative and in alignment with what we understand biologically about COVID-19. So we see that that a large percentage, so this is 36 out of the 63, so over 50% of pregnant women, and only about a third of our non-pregnant cohort wanted or needed to get a test for COVID-19. That's the first bar. Almost all, 30 out of 36 pregnant women, and only about 60% of the non-pregnant cohort were able to get tested for COVID-19. But this is where it gets really important, and it speaks to the baseline immunity of pregnant women. So we see that over 50% of the pregnant women who got tested positive for COVID-19, and 16 out of 18 of them were hospitalized. And so this does align with our understanding that pregnancy will reduce your resilience, your immunity to COVID-19 transmission, and then also increase the likelihood of complications downstream. And so this is the final sort of look at disruptions in care related to pregnancy. And we've used here the ECHO environmental effects of on children outcome. It's an NIH-supported survey that we adapted for this purpose. And what we've asked the pregnant women if they experienced any changes in their prenatal care as a result of COVID-19. And what we see that about 32% of them reported cancellations in ANC care. But also there is good news, because about 31% right here reported having more prenatal visits than planned. And 22% reported no change in their prenatal plan. Over close to 60% of the women reported experiencing moderate to extreme distress related to changes in their prenatal care plan. And about 50% of them reported that their care had significantly or somewhat worsened or significantly worsened. And then the most concerning piece of observation here was that about 31% or 32% women reported changing their birth plan from a hospital birth to a home birth. And about 35% reported changing their birth plan from a vaginal birth to a C-section. So I think these data certainly have their limitations given the fairly small cohort of participants. However, they are in alignment with, they are in alignment with other data that is emerging, and around pregnancy, there is very little COVID-19 related data. So we're looking forward to continuing this analysis and also expanding on it in subsequent rounds, as it has direct implications for practice and policy paradigms for pregnant women. I'll pass on to the next speaker.
Great, so I'll be talking, my name is Jeffrey Edwards, thank you Dr. Agarwal. I'll be talking about some of the differences in care as well as the testing availability as noted by race. So looking at our overall sample, we noted that there was a higher test positivity and hospitalization rate for our Black respondents compared to the white or Latino respondents, which is consistent with our nationwide data available from the CDC. So we see about a 9% positivity rate for all of the participants compared to a little over 6% for white respondents. And then similarly for hospitalization, you see 7.5% of African-American respondents being hospitalized with COVID versus only a little over 5% for the white respondents. But then when we break it down by our sample in terms of who wanted and needed a test, so from our sample of over 1,000, we narrowed it down to those who reported either symptoms or wanting a test due to exposure. And out of that population, we noted that this survey again was administered in September, that there had been equalization with regards to availability of testing. So we see that on the left, we have everyone who wanted or needed a test. And then out of that, each group experienced a drop off in terms of who was able to receive a test and actually got tested. But those were similar across the board, so 27, 24, 21%, still slightly lower for white respondents compared to Black and Latino respondents. But then within that group, again, of who wanted or needed a test and then got tested, we still had a relatively similar distribution of test positivity rates within that subset of our overall cohort, which was reassuring regarding over time the ability to ramp up testing to meet the need, but still overall, as we mentioned from the prior slides, disparities in who is getting COVID-19. So then as we also look at those who are able to receive testing, we wonder how long are people who get tested waiting for their results. So this is where we look at respondents that received results for their testing, and we see there are disparities here between the Latino respondents as well as in the Black and white respondents. So we see an increased proportion of the Latino respondents waiting greater than 5 days to receive the result, which could have great implications on activities and behaviors, especially for those, not only those who have been tested, but household members of those who have been tested, and decisions to engage in other activities outside of their household. And then when we look at the reason for those who weren't able to get tested, who wanted to get tested, we also see disparities in those reasons. So we noted that Black respondents were more likely to not know where to get tested. As you can see in this orange bar, closer to 45% of those who weren't able to get tested noted that they didn't know where to go, which again speaks to longer standing issues with information dissemination, as well as education on where people should be going to get testing and where sites might be safe for people to receive that testing. In addition to that, we also had a few questions analyzing what the impact of COVID-19 is on routine care. So similar to Dr. Agarwal's mentioning or overview of the impact on pregnancy and those outcomes, we looked at overall health outcomes and the ability to see a healthcare provider as well as to take medications that they normally take. And as we see on the left, there was an increased proportion of Black respondents who noted that they avoided going to a healthcare provider because of COVID-19 compared to both white and Latino respondents. And then that trend holds in addition to having missed a medication that they didn't want to take because they didn't want to leave the house. And so I think that this overall supports the narrative that we've had crafted and that has been honestly happening in the background for decades and even centuries within this country of disparate access to care and disparate, just the social determinants of health really playing out through this pandemic in multiple ways. And this, I think, was particularly concerning because it could speak to a longer term impact of COVID-19, even beyond COVID-19 itself, but other diseases that might have longer term complications because of that disruption in care. And so lastly, we looked at preventive therapeutic use, which interestingly also differed by race. So we asked if people have started taking any medications or supplements that they believe will protect them from COVID-19. And again, this was done in September prior to, and again, we still haven't yet had any vaccines approved or any prophylactic therapeutic FDA approved therapies. But this was still noting a difference in the perception of taking the medications that could prevent COVID. And we see a higher rate of Black respondents noting that, yes, they have taken something, as well as Latino respondents compared to the white respondents. And so I think, again, this speaks to the overall differences in dissemination of information. And it also can speak to underlying mistrust of institutions or things that might be there in the background that have informed where we are today with regards to COVID testing. And with that, I'll pass along to the next presenter.
Dustin, over to you.
Yep, sorry about that. Just, hello?
Yep, we
Okay.
hear you. Go ahead.
All right.
Thank you.
Just trying to, sorry about that. So the next section will be on vaccine perceptions and belief. We had about 12 to 15 questions around the COVID-19 vaccine, but since this isn't a vaccine-specific seminar, I'm just going to limit the analyses to these 3 questions. So we, as you can see in the figure at the bottom, 65% of the nation report willing to receive the flu vaccine in the upcoming year. 55% report willing to take an FDA-approved COVID vaccine as soon as it's made available to the public. And only 40% overall are willing to participate in a COVID vaccine clinical trial. The 55% that are willing to receive a COVID vaccine is similar to some of the estimates that came out, I think just a few days ago. That estimate is now around 50% of the US population willing to take a vaccine, and we can talk about the implications of that to control the pandemic later on. So for the next set of slides, I'll be examining these same 3 indicators, but by gender here, with male in the blue and female in the red, and then by race, ethnicity, and then by age groups. So this graph shows the willingness to participate in a clinical trial with the males in blues, females in reds. And you can see, some differences in the willing to receive the flu vaccine, but about a 15% difference between males and females in participating in a clinical trial, and a 15% difference in receiving the COVID vaccine when available. For this figure, the x-axis remains the same, but now we have white individuals in blue, black and red, and Latinos in gray. And starting on the right again, we see little difference in receiving the flu vaccine between race, ethnicity. However, we can see about a 10% difference between whites and blacks for receiving a new COVID vaccine, with no difference between Latino, Hispanics, and whites. And we see that similar difference this time for participating in a clinical trial, with about a 10% difference amongst blacks and Latinos compared to whites. Again, the same axis, but now we're looking at age. So going from left to right, younger to older age groups. We see a little difference in willingness to receive the flu vaccine by age, with the exception of this older age group, approaching 80%. For receiving the COVID vaccine that would be FDA approved, we see a decrease in willingness among those ages 45 to 64. And then lastly, in regards to the clinical trial participation, we see a much higher percentage of young folks who are willing to participate in such trials. This finding is not that unexpected. My pop-ups now. This finding is not that unexpected. This is just from, I think, CNN. Is there's been a movement among young people who are willing to purposely get infected with the coronavirus in order to speed up vaccine development. For those who reported that they weren't willing to, sorry, this should not be reasons for not participating in a trial. It should be reasons for not receiving the COVID-19 vaccine as soon as it's made available. There's a sleuth of reasons, none of which were, when we looked, different by race, ethnicity, and age. But overall, we can see that 40% of the concerns were safety related, followed by 20% of the concerns around effectiveness, and another 15% who were concerned about some long-term health consequences. We did ask people if these weren't their concerns to please specify, and it was about 10%, and they were quite interesting. These are just verbatim. So here we can see some of the politicization or divide among the country. We have some that don't trust the current administration, and we have some that don't trust Bill Gates or Dr. Fauci. Another group of reasons, which we're all working on coding these, since there were some common reasons, mainly around the mistrust of government, but also really I'm happy to take the vaccine, but I don't want to be the first one. So, I said, I would do it, but I don't want to be first. Not out long enough, too new to see true results. So perhaps, taking it several months after there's been a more documented, established safety profile. I think all in all, we can see that once we get a vaccine, an effective vaccine, how challenging from the 55% willing to receive it to these age, racial, ethnic, gender differences and acceptances and the myriad of reasons for not wanting it, how challenging it will be to reach enough of the population to produce herd immunity. For the sake of time, I didn't include a slide, but there were also, we asked about sources of vaccine information, and that did vary a little bit from CDC to personal doctors to family to social media. So not only is producing the vaccine challenging, but the distribution I'm anticipating will be equally. And with that, I'll turn it over.
Thank you, Dustin.
Thank you, Dustin.
Over to Ankita. Yeah.
Thank you. So I'll be presenting on some of the preliminary findings from the school reopening module. And we asked respondents who are parents about their perceptions about school reopening in the 2020-2021 school year, as well as their preferences for different safety measures when schools reopen. So as you all might be reading, there's actually been significant concerns about schools reopening safely, and also about how school closures might actually, in fact, be exacerbating inequalities because families might have varying levels of access to technology and internet, as well as the ability to do homeschooling. So in the school reopening module, we asked 510 caregivers or parents questions about school reopening and school safety measures. And of the 510 respondents, nearly 50% of parents had children in elementary and middle school. 22% of them had kids in high school, 11% in daycare, and 19% in daycare, elementary, middle, and or high school. And 77% of parents also reported that their children attended public schools. And in terms of demographics of the parents, we had roughly the same number of male and female respondents. Since we had oversampled for race, we see a higher percentage of respondents who were white, African American, and Latino. About 80% of our respondents were under 45 years of age. More than half had a bachelor's degree or higher, and about a half earned $70,000 per year in income. So overall, respective of race and ethnicity, as shown here, parents expressed generally high access to the necessary resources that were required for supporting their child's remote learning needs. And when we asked parents, are you planning to send your child to school this year? We found that about 50% of parents indeed had plans for their children to return to school. About 18% of respondents said that their plans depended on the plans that the school district makes, and about 32% did not intend for their child to return to school during the 2020-2021 school year. And interestingly, we also found that irrespective of parents' decisions about their child returning or not returning to school, there was generally a high level of concern about school safety across all parents. And only 15% or so were not concerned about their children actually returning to school, as we see in blue over here. And while most parents were either slightly concerned or very concerned, it was interesting to note that we found that among Black respondents, there were higher levels of concerns regarding school safety related to COVID-19 when schools do reopen. So next we asked parents, what describes your feelings about your child returning to school? And we found for about 30% of parents that the availability of vaccine was a critical condition for their child to return to school. Similarly, for 30% of parents, encouragement of safety guidelines such as social distancing, hand washing, face covering, and temperature checks was an important condition. And for about 20% of parents, the enforcement of these school guidelines, of these school safety guidelines was a critical condition. And for the remaining 20% of parents, their feelings about sending, sorry, I'm just trying to go back. And then for the remaining 20% of parents, their feelings about sending their child to go back to school depended on the school district plans and other reasons, for example, being forced to send their children back to school for financial reasons. So despite today's national political climate, we found that politics didn't really significantly influence parents' decisions about school safety. However, we did note something that was interesting. We noticed that, sorry, I'm having trouble navigating these slides a little bit. So what we did note was that it was interesting to see that parents with Republican leanings, as shown in orange bars here, encouraged school safety guidelines. However, they didn't necessarily see their enforcement as an important condition for their child to return to school. And in terms of school reopenings and safety practices, we were also curious to see whether perceptions of these safety practices varied by the school type, whether parents' children attended public schools, private schools, and religious schools. And to give you some context, parents whose children attended private and religious schools were largely white. They earned more than $70,000 per year and largely had bachelor's or a graduate degree. So when we asked these parents, whose children attended public, private, and religious schools what their top 5 priorities were for health safety practices in order for schools to reopen, we found that the top 5 priorities was actually largely similar across public, private, and religious schools. However, the relative ranking of these priorities actually differed. So we found that COVID-19 vaccines, staff being required to wear masks being available for all, as well as COVID-19 testing were seen as common priorities across public schools, private schools, and religious schools. However, we also noted that students requiring masks were only priorities for public schools and religious schools, not for private schools, and that temperature checks was a priority only among private schools. So finally, in this module, we asked parents, how likely are you to change or switch your child's school if the current school does not follow your desired recommended guidelines for school safety measures? And surprisingly, a majority of parents were actually willing to switch schools, but we did find that Black and Latino respondents were more likely to consider changing schools due to safety concerns relative to white respondents. So to quickly summarize, we found in our preliminary analysis that 50% of parents were planning to have their children return to school during the 2020-2021 school year. However, about 80% of them expressed safety concerns. We also found that about half the parents viewed either the encouragement or the enforcement of safety guidelines as a critical condition for their child to return to school. And about 30% of parents viewed vaccine availability as a very important condition in order for their children to return to school. And in terms of next steps, we'll continue analyzing the data and explore interactions between parents' characteristics and their perceptions about school reopening and school safety. And with that, I'm going to turn it to Jeffrey.
Thank you, Ankita. So I will talk about kind of building off of what she was talking about in terms of elementary and secondary school, the impact on higher education. So we surveyed.
Jeff, you're muted. Can you start again?
Yeah, sorry, I was having issues with the control. But yes, looking at our survey results, we had 17.8 respondents who were engaged in higher education, either college or university. And as you would expect, the age distribution is a relatively young set of respondents that noted that they were still in school, and a relatively even distribution between male and female respondents. And as noted before, we had oversampled Black and Latino respondents to get a better indication of of the disparities due to racial inequity. And the questions that we focused on here were, one, if you are in university or not, and then the next three questions: have you or are you considering pausing your studies because of COVID-19 pressures? Do you have access to necessary technology resources to support your studies? And do you have a place in your home or elsewhere where you can study or do your academic work undisturbed? And so looking at these, we found that COVID-related unemployment and continued higher education, there was an overall association between those who lost their job during the COVID-19 pandemic and were able to continue their studies versus those who did not lose their job. And so we saw, as you can see, close to 82% of those who lost their job during the COVID-19 pandemic chose to pause or considered pausing their studies, versus only half of those who did not lose their job during the COVID-19 pandemic chose to pause or not continue their studies. And so I think that this indicates that a lot of this decision whether to continue with higher education is tied to whether or not they were impacted financially, potentially through a loss of income. However, continuing, something that was very notable to us was that Black respondents were actually still less likely to report considering pausing their studies. So if you look at this, we have the overall data, and then looking at each of the questions on the far left, we have you or are you considering pausing your studies? And there's a lower proportion, this is statistically significant with the p-value of 0.03, Black respondents saying that they were less likely to continue their studies. And we believe that this, less likely, to pause their studies. And we believe that this could be related to overall pressures faced by this population and long-term planning in terms of worries about not being able to find employment if they did pause their studies, worries about a lot of additional stressors added during the COVID-19 pandemic. So we believe that this can represent the potential unequal reactions to and responses to how to continue with or pause their university study. But something that also was interesting to us is that there were relatively equal access to necessary technology resources, which is not super unsurprising because there are a lot of technology available within the US, especially with regards to phones that you can use for Zoom or class, as well as laptops, and internet access has expanded, though still that we would note likely disparities between full access or speed of that internet access. And then lastly, we noticed such a small decrease in terms of having a place in a home or elsewhere where they can study and do undisturbed academic work or a dedicated workspace. And we found that although this doesn't come out in this particular question, we are interested in following this question over time and seeing whether this actually impacts grades or academic performance long-term, based off of the trend that we're seeing that Black and Latino respondents reported slightly lower dedicated workspace. And then with that, I'll pass off to Alex.
Yeah, thank you very much, Jeffrey. I am now going to introduce you to our module on stigma and agency, and I would like to start with a quote by WHO, and particularly direct your attention to the second part where it states, "It exposes people to violence, harassment, and isolation, and it stops people from accessing health services and prevents public health measures from effectively controlling pandemics." So this really nicely highlights the secondary downstream effects stigma and discrimination have on the health of humans, including mental health issues and violence, but also on our pandemic response capacities and our performance, especially the repercussions on public health response measures or public and social health measures, as well as non-pharmaceutical interventions. And throughout the next slides, I will briefly introduce you to our methodology and then highlight some key results, which first of all, we will present the overall results, and then we did some stratifications by region based on the census, as well as race and ethnicity. So our methodology and questionnaire design for this module is quite congruent with what has been introduced to you before. We have one lead question, which is, for the following questions, please indicate whether you agree or disagree. And then we had 10 questions related to stigma, which included stigma associated with wearing masks, getting tested, as well as feeling ashamed. And we also had 5 questions that were related to agency, which included access to information and access to resources. So for these questions, there were 5 answer categories ranging from strongly agreeing to strongly disagreeing. And there was also a category for preferring not to say. And we then collapsed these categories into a binary variable for our analyses, which basically covered agreement versus disagreement. And we then did descriptive statistics and estimated proportions for the US population based on our survey, and also conducted multivariable logistic regression models to estimate adjusted odds ratios. I will now start with the first results on our stigma-related module. And these first 5 questions are mostly centered around people being afraid to wear a mask, as well as testing. And the key takeaway from our overall results is that stigma associated with COVID-19 is highly prevalent in the US. So the highlighted bar right here shows that approximately 2/3 of our respondents reported that they would be afraid that people might treat them badly, so that they would be stigmatized if they do not wear a mask. So very key takeaway here is that stigma associated with COVID-19 and related behaviors is really highly prevalent in this country. We then further looked into this by region based on the US Census, and we found some regional variation, especially when it comes to hesitating to get tested, as well as reporting that you are willing to notify your contacts or people you might have exposed once you find out that you got COVID. So these are the 2 highlighted groups of bars, and we can see that there's quite some substantial variation across the regions, with the bar in the middle, the Midwest, reporting substantially higher proportions or prevalences compared to the Northeast, for example. On top of that, we looked into stratifications by race and ethnicity for the 3 major groups in our data set, which were white American, Latino populations, as well as African American and Black populations. And we did not find significant differences in the answers to these first 5 stigma-associated questions. So as you can see here, the bars are fairly on the same level and the confidence intervals all overlap. So no substantial differences in stigma associated with wearing masks or hesitating to get tested, for example, by race. I will now transition to the second set of questions associated with stigma. And these were more focused around feeling ashamed. And here we can see that for our overall results, 1 in 4 US Americans actually associates shame with COVID-19. And this ranges from 1/4, so approximately 25%, up to 42% for the highest bar on this graphic, which relates to people reporting that they think that people who actually get COVID might have behaved responsibly. So once again, key finding that this is more prevalent than we might think. And our association by region showed once again that these perceived feelings of shame associated with COVID-19 do vary by region. So I would like to highlight the first group on the left right here, which asks the question if you would feel ashamed if a family member got infected with COVID. And here we see substantial variation with the Northeast in blue and the South in red, reporting higher prevalences than, for example, the Midwest and the middle. And similar findings were observed for the question about people having COVID behaving irresponsibly, as well as for people reporting that they think that people who got infected with COVID should feel ashamed. So once again, higher variation with higher prevalences in the Northeast and South. If we look at this by race, similarly to our first stigma, a group of stigma questions, there was no significant differences in the response to these questions. So there's a bit more fluctuation on these graphs, but still it's fairly the same level, and our confidence intervals overlap. Which makes me now transition to our agency-related questions, particularly to those regarding resources and information. And we found that there were quite a lot of people responding that they do have adequate access to resource and information. However, they also felt like they lost control due to this pandemic. So highlighted here are approximately 50 to 60% of people reporting that either they do have less control over their life as compared to pre-pandemic periods, or that they don't really feel like they have control because other people are actually making decisions that affect their family and their life. For this question, there was no variation across regions, so we're not showing these results, but they look very, very similar. So we got high resource and access to information and a lack of control across all regions. However, an interesting finding was that when we stratified by race and ethnicity, there was substantial variation regarding the loss of control, which is highlighted here. So you can see that both respondents from white American as well as Latino backgrounds reported perceiving to have less control over their life at substantially higher prevalences than African American respondents. And finally, some preliminary results on a driver that might be underlying all this is the responses to a question that was part of our broader survey questionnaire regarding if people lost their job or more than half of their income due to COVID over the last months. And here we saw significant differences across racial subpopulations. So as you can see here, particularly the Latino population reported substantially higher proportions of having lost their job or having lost substantial amounts of their income due to COVID compared to other populations such as the white American population. And to summarize our key takeaways on this module on stigma and agency, we would like to highlight that these two represent key factors in our broader pandemic response and recovery activities. So from what we've seen in the literature thus far globally surrounding the issue of stigma and discrimination associated with COVID-19, this seems to be focused mostly on low and middle income countries, whereas the US literature on stigma at least is centered around healthcare workers and healthcare practitioners. So with our results here, we report novel and important findings given the potential impact of stigma and discrimination as well as agency on, first of all, the engagement of the public in essential measures such as contact tracing, as well as the adherence to public health and social measures or non-pharmaceutical interventions, which are key interventions to contain the spread, especially since we don't have a vaccine yet, but also access to testing and timely care seeking. So in conclusion, these findings highlight the need to decouple infection with SARS-CoV-2, which means getting COVID-19, from stigma and discrimination associated with this disease, given that these two have very serious consequences on controlling the COVID-19 pandemic through the long-term repercussions on our public health measures. And with that, I would like to pass it on to our final summary.
Thank you, Alex, and thank you to the team for doing a really phenomenal job of digesting what is really a mountain of data. And thank you to the audience for sticking with us to this bitter end, or sweet end. I think we really appreciate. We've had about 100 participants who have been with us throughout the hour. And I'm thankful to the team members who've been responding to the questions in the background while the presentations have been ongoing. I almost want to give everyone a moment to take a deep breath and process all of that data that we had a chance to observe, and then while you're doing that, let me maybe reflect a little bit on some of the implications and potential policy response. I think what we have seen, as some of our speakers pointed out, and as we have heard in the media and in the literature, that targeted interventions do work, and that they are needed to address these inequities and improve the experience and outcomes in marginalized populations. I think, however, what this September data highlights is that despite these important gains, and the acknowledgement, I think, across the country that there are deep racial, ethnic, and socioeconomic disparities that manifest through this COVID-19 pandemic, we do have more work to do. We have to address inequities that persist in access to testing and in rapid turnaround of test results. We have to acknowledge that decades of systemic racism and exploitation of people of color in this country have led to decreased trust in therapies and in preventive measures, notably as we saw in the vaccine data module. This can both lead to harmful exclusion of minorities in early vaccine and therapeutics trials, but it can also lead to decreased uptake and coverage of the vaccine once it does become available. So the time is now to intervene and build public trust through known institutions among these populations to ensure that these inequities do not persist once a vaccine becomes available. We also need to address the secondary impacts of the disproportionate burden of COVID-19 on these vulnerable populations. And that includes addressing, as you just saw from Alex's last slide, the job losses that are clearly aligned with these different population subgroups, and the inevitable mental health consequences of these losses and their effect on sort of the long-term trajectory of these individuals in terms of primary, secondary, and graduate education. I think we cannot underestimate, and just to re-emphasize this shockingly high prevalence of stigma, that I think in the literature we've seen a lot of discussion about stigma against healthcare workers, but here we see stigma associated with COVID-19 and this sense of shame associated with infections that could be a very important barrier to public health interventions and control measures, such as contact tracing. And last but not least, I think we do need to pay special attention to special populations, such as pregnant women, that need to be addressed, and prophylactic measures need to be taken to ensure that declines in antenatal care and quality of care do not drive an increase in adverse maternal and child outcomes, which we already know are adversely affecting populations of color in the United States in terms of an excess maternal mortality and poor neonatal outcomes. So with that, I want to again thank all of you for joining us today. We look forward to several more of these as more of the pulses are sent out into the population, and we get more data that allows us to look at trends over time, in addition to how the pandemic and the US pulse is changing as we move through time. With that, I invite our moderator, Dr. Kelbarczyk, to take us to any pending questions that maybe not have been answered by in the chat. So Anna, over to you.
Thanks, Len. It also looks like most of the questions were answered by a member of the team. So if there's anybody who's still on, who's finding that their question hasn't been answered, you know, Len, I know you weren't able to look at these because your screen was up, but there was a lot of questions about looking at the data, specific types of data, regional differences, etc. And I know that both Smisha and Dustin were engaging with some of the questions. So I might ask if one of you would like to say anything about what you were seeing in the questions and some responses that you might have to share with the wider group of participants. Smisha and Dustin.
Yeah, sure. I'm just looking through the questions again to see what insights we're gleaning. So I think we received some great input on future questions or analytical approaches that can be included. There's definitely a lot of interest in regional analysis, and so we're still, for the stigma work, there is some regional analysis, but we're in the process of undertaking regional analysis for the other modules, and we look forward to sharing that in the future, especially as we administer more surveys and are able to look at the regions longitudinally, especially with things opening up. And now I think we're experiencing a second wave closing back down, what kind of regional changes we might experience. There were several questions about looking at the pregnant population and clarity on who the non-pregnant population was. And that is, of course, non-pregnant population was a group of women only, not men, who were matched for age and other demographics. And I think we received some good insights on why we might see the differences in risk perception, as well as the need to look at the pregnant population disaggregated by the demographic, socioeconomic, especially aspects. And we don't have enough data on the pregnant population to do that, but we recognize the critical importance of undertaking that type of analysis in the future. But as of now, we actually don't have a large enough sample size to be able to disaggregate the pregnant population further. Dustin, do you want to dive in with other questions?
I think just that I didn't present necessarily the regional differences for the COVID vaccine acceptability participating in the trial, but I did there was a significant difference with the Midwestern part of the US being more likely to receive the COVID-19 vaccine. And I think there was a comment about our weighting and everything. So we did, if there were, if the Midwest population has a 10% African-American population, as compared to 30% African-American in the South, we did apply those weights on race by the census regions.
So Dustin, could you clarify if we are able to look at, is the race data representative by region as per Greg's question?
It is with our weighting, it is.
Okay.
And just to say a quick note about this methodology, I think many of you may have noted the speed with which we were able to fill our quota sample in Dustin's initial presentation. I think that speaks to the capacity to capture a lot of this policy relevant data in a very short amount of time, and the capacity to oversample specific subgroups of interest as we move forward. So I think, as we've done with race and ethnicity and region and income brackets, I think we could, if there was interest in a particular subgroup, oversample a particular subgroup as an effort to be able to speak to the experience of that group. As you start to substratify and look at complex interactions, obviously the available sample size will impede your ability to achieve statistical significance. But I think given the main objectives of this particular pulse, we're quite satisfied with the quality of data that was obtained.
So to follow up, I think like with this one, we were able to just look at grossly race, ethnicity. You know, we had about 400 African Americans, 400 Latinos, and around 600-700 whites. But maybe in the future studies, the pulse, we may want to even increase the sample size so we could look at differences between young Black men on stigma and young white men as examples. So looking at these interactions or combination of effects across age, race, gender.
And are we able to take additional questions that folks might have on the call?
Yes, we can take additional questions. If anyone on the call would like to, I think that you can raise your hand, and we can also call on people if you'd prefer not to type. So we can do that.
I know our colleagues from J&J are on the call as well. If
yes, I saw some people introduce themselves early on, so we can certainly field those questions. And I think if someone raises their hand, Megan can open up their microphone. But otherwise, I don't think we have any typed questions in the chat.
Great. It speaks volumes to the clarity of our respected colleagues here. So, and I don't think there's ever anything wrong with giving people back a 15-minute window to take care of biological needs prior to what is likely to be a next Zoom that follows this one. So. I think if there are no additional questions, we just want to reiterate our thanks to everyone who's joined us this afternoon, and really acknowledge the privilege that we have to be given the profound responsibility of exploring this important data. I think these are issues that we take with great trepidation and with an understanding of the responsibility that we have to treat this data with care and to represent the findings authentically as the data do speak to us. So maybe with that, we say thank you to everyone, and we look forward to you joining us at the next Pandemic Pulse webinar.
Great, thank you everyone so much for joining our session today. We're very excited at the Center for Global Health to be able to put this on and to do this spotlight session. So we will be reaching out again when we have our next one. Thanks again to all of the panelists, everyone who attended and stuck with us today, and we'll see you all again soon.